These are the fancy objectives that were emailed out to us, but these are my non-fancy objectives. So just a general question like, what is this thing, emergency psych? Trying to propose a definition. What kind of resources do we have available to us and professional organizations? And then out of the very many topics in emergency psych, I tried to pick 3. And those would be medical clearance, because what's more exciting than labs? Suicide, and then agitation. Well, now that's really exciting, right? What's more exciting than a patient coming at me? So how do we deal with kind of each of these things? So here's Michael Scott. He's here to tell us what the definition of emergency psych is. I guess he works on the American Association of Emergency Psychiatrists, which is the AAEP. And he says that emergency psychiatry is the clinical application of psychiatry in emergency settings. So that makes a lot of sense. It's like a psychiatrist, but they're in the emergency department. And they treat conditions that require psychiatric interventions like suicide, substance abuse, depression, psychosis, violence, or other rapid changes in behavior. So I would say, all psychiatrists deal with this. And then I suppose in emergency psych, the acuity is just a little higher. One big difference, as far as I can see it, between, let's say, emergency department psychiatry and inpatient would be that you're dealing with a little more. Meth intoxication looks different in the emergency department than it does once they go over to the BMC, right? The BMC, they're sleeping. In the emergency department, they could be sleeping, but oftentimes they aren't. I wanted to just say what else we could have talked about today, because it broke my heart that we could have talked about all these things. So we could have talked about like operational improvement, because the emergency department operates, it's kind of like an assembly line with an unlimited number of patients on the forward end, and then all these things that prevent throughput. And so we could have talked about like throughput in the emergency department, how patients flow through that, how multidisciplinary teams work. It's also kind of a strange intersection between the hospital and the not hospital. So like it's assumed in emergency psychiatry is also like crisis resources that are community-based, both to prevent incorrect utilization of the emergency department and to provide patients resources once they're discharged. So, we know about, for example, using Suboxone in the emergency department to help our patients with opiate use. But what's the point of giving a patient Suboxone in the emergency department if there's nowhere to send them after, right? And so really all of that would be a part of emergency psychiatry kind of as well. And then lab clearance. It also has evidence-based guidelines to treat behavioral emergencies related to all the psychiatric conditions as bullet point 1. Toxidromes is super interesting. This is an area that I got a little nerded out on. Essentially, it's a 3-year fellowship. Toxicology is a 3-year fellowship in pathology. And I was like, what? There's people that just like learn about this for 3 years. And there's a bunch of studies that really, and I would say it's true for me at least, that we don't have a lot of exposure to this. I mean, we see patients that overdose, but someone literally was a doctor and completed residency and did another 3 years in this field. So there's obviously a lot to learn there. So when we say things like we're calling poison control, this is who we're actually calling, are these pathologists that do this kind of stuff. And there's overlap with that, of course, in emergency psychiatry. And then, of course, there's suicide and need for psychiatric admission and determining whether psychiatric admission is warranted or not. Here's just a smattering of resources. The first are online, and then a couple books I read, and then after that, a couple apps. So the American Association of Emergency Psychiatry, or AAEP, there's no real fellowship in psychiatry at this point, no accredited fellowship. There's one at Arrowhead, and I think there's a couple other in the area as well. But it's not like an ACGME accredited fellowship per se. So this costs $200 for attending physicians, this American Association of Emergency Psychiatry, $50 for residents and students. It actually comes with, I don't know why they named their yearly conference Noob. That always kind of makes me laugh. Like, come on, come to Noob, you noob. It's like, I don't know why they're doing this. National update on behavioral emergencies. And you actually have access to all the yearly conferences and all the conference materials for free if you pay the $50. For the last 2016 to 2021, they haven't put 2022 yet, but they put everything else before that. So you can look at that. Without the membership, you have links to pretty good resources, just like scanning around. I think I put those on this next slide. These are resources not for AAP, but for the Emergency Medicine Foundation. So there's this weird, since emergency psych isn't like a thing quite yet. I mean, it kind of is, it kind of isn't. It's kind of like every professional organization has their own kind of emergency psych resources. So the Emergency Medical Doctors Association that practice emergency medicine, they have an emergency psych section, and that's here. Your consult liaison psychiatrists have like an emergency psychiatry interest group. SAMHSA, even like the substance abuse and mental health treatment, they have their own little section. And then you can kind of piecemeal it together. And I think the AAEP does that pretty well, piecemealing it kind of all together. And then they give you a journal access to emergency psychiatry too in there. So some cool tools here. SAMHSA, I mentioned that. There's this promise of 998. So in emergency psychiatry, there's a thought that you can call 911 for all non-behavioral emergencies. And in the future, there should be a number 988 that you can call for all behavioral emergencies, so that those things are kind of distinct. So law enforcement may still be involved in that, but at least you're kind of calling a different number so that it gets diverted differently. There's the American Foundation of Suicide Prevention. There's follow-up from ED. So there's been a bunch of studies that say if you give someone just like a postcard after they leave the ED, like thinking of you, I'm being somewhat facetious there, but it's not a lot. It's like, I hope you're doing well. Then that actually prevents suicide or calling them, which I think our VA does very well. Joint Commission on Suicide Prevention, they have like a 30-page document, which I hyperlinked here. The American Academy of Emergency Physicians, this is the other professional organizations. And then even the California Hospital Association has an ED toolkit. So some kind of interesting overlap. Here's some books I read in preparation for this. So The Substance Use in Acute Psychiatric Patient. I really like this one because it gave me probably more exposure to just like intoxicated states that I've had or thought about previously. And then the Big Book of Emergency Psychiatry is kind of a nice overview, a lot of which you'll know. And then it has kind of an emergency psychiatry bin. And then if you want to know about workflow stuff, then this is a good book beyond the scope of today. Here's an interesting app that I ran across. So it's the American College of Emergency Physicians. So this is the Emergency Physician Association. And they have this toxicology app. There's a couple other toxicology apps. There's a MicroMedX that's pretty good, which I put down here. And there's a ToxEd that I put down here as well. So I think most pathologists use either MicroMedX or ToxEd when they're trying to poison control clear people. And then here's another app, MPOC, which has simple algorithms for various emergency medicine, because it's made for emergency medicine doctors for various disorders. And it's kind of interesting. They have one here for agitation of the elderly. They have one for autism spectrum disorder. Like out of all the emergency things they could have chosen, it's kind of interesting that these are the ones they chose, I thought. Buprenorphine, and then below that is their suicide one actually down here as well. So like you're looking at these and it's like, these are all the things people can come to the emergency department with. And behavioral emergencies are going up, up, up. It's probably close to like 5 or 10% of all emergency department visits now. So we keep seeing a rise. So with that, we've done with the resources. I can now actually go into one of my 3 points. And I will spend 10 to 15 minutes on this point. After this point, we'll be more than half the way done. So you're doing a great job. I'm saying that kind of to myself too. I'm doing a great job. All right, so this is a myth of medical clearance. Before we start, so the question is, are we going to bust this, like these myth busters, or is it true? So do we need medical clearance for every patient? And these are just some warm-up questions that our studies are going to answer. So how often do labs alone, let's say, help us come to a proper diagnosis of a medical or a psychiatric condition? That's just a question to think about. Because if labs alone do that, then it's going to be a lot better to order labs. If they don't do that very often, then it's not going to be as good to order labs. Which is more important, lab studies or history and physical? Again, I've known, I remember in medical school, there's an ED doctor, and it's just like every patient that comes in, it's pan CT, all the labs and everything, right? No matter what the chief complaint is. And then he goes and interviews them after that kind of comes up. So which is more important? What is the rate of, let's say, true positives? Any lab test, right, is going to have true positives, false positives, true negatives, and false negatives. Like, what are these things? How often will labs even lead me astray? How long will they be correct in their assessment, and how often will they be incorrect? And then just, of course, the cost. What would be the burden or not burden of ordering labs on every patient? Do labs change disposition? So, emergency department is all about where is the patient going? So does it change whether they go to do labs change whether they go to the psych hospital, whether they stay in the emergency department, whether they go to the medical floor, whether they go back home? That's probably one of the most important questions we could ask. Could ordering labs harm my patient? Kind of like if all my labs were giving me false positives and false negatives, well, then it's possible for them to. If it put undue, let's say, monetary burden on patients, then that would. Or let's say, what if, I hate to say it, but what if like psych hospitals sometimes said, oh, we can't accept that patient that may actually need psych admission because their potassium is 3.0. Not that that would ever happen, but just what if that happened, right? And should I order labs universally for all patients? And if not, because it's like I have a choice. I'm either ordering labs for everyone or I'm not. And if I'm not ordering labs for everyone, then how do I go about deciding which labs I should order and when to order them and like how to do that? All right. So I don't, to be perfectly honest, I don't know how much of these I should go over. So essentially there's like 1, 2, 3, 4, 5, 6, like there's gonna be like 10 studies here that I've kind of summarized. We'll just kind of go through these quickly so that we can have questions at the end. And that's why I created the bold parts. So here's a study from 1977. This was on 636 patients. They got these labs. They found 3 UTIs. So overall, it helped 0.63% of patients, or 4 out of 636. And then you have to decide how much 3 UTIs and 1 dehydration is important for 636 patients. Here's Ferguson and Dudlin, 1986. They use 4 risk factors. So they're trying to decide, like, what if we just did these 4 things and then screen people? So they're not doing universal screening, they're creating things and then doing screening. And their risk factors were age greater than 65, altered mental status, drug, alcohol use, weight loss more than 10%. They were like, let's order labs for these 650 people. They said that they caught using this high, and then they ordered labs on everyone just to see. What they caught 86.4% of lab abnormalities and missed 1.5% with this. And they caught 5 UTIs and 5 electrolyte abnormalities. So we're kind of picking up a pattern here. Age alone isn't a good tool to screen. So these studies kind of go together, because Coleman says if you're going to use just age by itself as a risk factor, whether to screen for labs or not to screen, it's not good. It doesn't change whether you should screen with labs or not. Dolan in 1985 said false positives on labs are much greater than true positives. Kind of interesting. True positives were 1.8% and false positives were 8 times higher. And then the lab diagnoses alone, so without a history and physical, you're making lab diagnoses on this study with like less than 0.1% of cases. So labs alone, it seems, according to this study at least, aren't very good at screening. This comes then to how good is history. History then is much more important than labs, according to Olshkar in 1997. They did a 345 patient study, and 94% of the patients were found to have medical problems based on history alone. Do you have diabetes? Yes. Is your A1C controlled? No. So that works 94% of the time. And only 4 patients were missed by history, but 1 was febrile, so that's vitals, right? So that's not history, that's just vitals. 1 anemia, and then 2 mild low potassium. So the question is, we screened 345 patients to get these 4 things. How helpful is that? Janik and Adelberry 2012 basically supported Olshkar 1997. Only 1 patient had abnormal labs in this case, but their sample size was smaller. The patient was also febrile and tachycardic. So I can guess that they probably had an elevated white count in that case. Ammon and Wang 2009, labs don't change disposition. So they did 375 patients with 4 abnormalities. And you can catch this. I mean, are any of these changing the disposition of these patients if these are psych patients from the previous things? And that's kind of, hey, the answer is looking like no. Parmar 2012, 191 patients. They changed the disposition of 1 patient because of a positive acetaminophen level. And then the cost per patient was 197. So essentially, if you multiply 197 by 191, that's how much it costs to screen everyone. And then to get 1 value, that's how much it costs to get 1 significant lab value result, right? So we're kind of talking about like thousands of dollars for the significant lab value result. So Gregory summarizes this in 2004. Overall results indicate that the yield for routine laboratory investigation is extremely low. For those of you that are in CAP fellowship, there's a couple studies here for you as well. I'm not forgetting about you. It's this one, I think. No, it's this one. Pediatric patients don't benefit from routine screening. Donofrio in 2014. So this is a huge sample, 1,082 patients, 80% had screening labs. They'll go over what the screening labs are. I think it was a UA and a UDS. Labs changed disposition in 7 kids, but 6 were identified with history and physical alone, and the labs were just kind of extra. This is the kind of biggest one, I think, overall, is in terms of my thought and the harm it could be doing, is it, really it just sucks sitting in the emergency department. The longer you're in the emergency department, the more angry you get, right? The more like, it's not helping people with behavioral emergencies. You're going to feel just worse. You're going to feel probably more suicidal, probably more angry, more violent outbursts. And so it's adding, on average, labs add 6.8 hours of a patient's time in the hospital and $970 per patient. So just a lot of costs. So this led to the American College of Emergency Psychiatrists position statement. Routine laboratory testing of all patients is very low yield and need not be performed as part of the ED assessment. I found all this very surprising. Here's a couple other studies. I think we get the drift though. I found all this very surprising. And really, my question is, my question is, I'll just skip ahead because that's my question is why do we perform routine screening? We really haven't. I think one of the, at least this one was true for me. We haven't thought about the necessity or the cost benefit ratio of routine screening. So hopefully we've kind of done that a little now. I think it's something we always do. So there's this funny Dilbert comic that says that. There's a bunch of other funny memes online. And I really think, in thinking about it, and I'm curious during question time if you have any other thoughts, I'd be curious to hear what you think. But it's really also a prerequisite to admit it. Like, a psych hospital isn't going to accept you, right, in the area unless you have a CBC and CMP, a UA, a UDS, a COVID, right? It is the bar of admission. And so I think it says how widespread this belief is. And then the question is how does that change on kind of a systems level? I don't have any good ideas except for what's done. So essentially what UC Davis was the one, UC Davis and their network up north in Northern California, where I'm from, were the people that created the SMART criteria, which we're kind of going out of order now, but that'll be the criteria by which we screen whether labs are necessary or not. And really, in order to address this 3 here, the prerequisite for admittance, they had to get like every major player in that whole area together. So they got like every hospital administrator together. They got like a lot of the psychiatrists together. They got all the emergency departments together, and they created this like emergency medical kind of board, SMART team. And it was like, all right, guys, this is the problem. The problem is everyone needs labs, but all the research that we have says that they really don't. Like, and then they talked about it, and then they said, yeah, if they're SMART cleared, then that's okay. They can come to our hospital without all the labs. And so I think this will, over time, happen more broadly. And it's a good model for, and this is a whole website too. So this is one that I didn't mention. This is the SSVMS website, and they have described on this website how they implemented all of these kind of policies and procedures and how they changed the whole hospital system really in that area. So pretty cool stuff. So this is the article that they created. This is from 2017. The SMART Medical Clearance Protocol as a standardized clearance protocol for psychiatric patients in the emergency department. This is the form, which you can find on the SSVMS website. Do you have a new onset psychiatric condition? Do you have these medical conditions that require screening, diabetes, possible pregnancy? I like how they just include other. Think about everything else. Do you have abnormal vital signs, temperature, heart rate, blood pressure, respiratory rate, oxygen, abnormal mental status, right? So delirium, right? You can't answer your name, month, year, or just substance intoxication, right? Which is why they say clinically intoxicated. There's another substance intoxication scale that you can use, the HII. Risky presentation, they're less than 12 years old or greater than 55. Possible ingestion, eating disorders, and then these levels. Now I was just looking at this again last night, and I was like, wait, what happens again if you answer one of these yes? And then I was like, oh yeah, it says here in the bold. If all 5 SMART criteria are checked no, then the patient is considered medically cleared. I hate that word, but it's what it says. Because what is medical clearance? It's just difficult to kind of even know. What is like clear? It makes me think of Scientology. Like Tom Cruise is clear. I'm like, am I a Scientologist wandering around? Anyways, I won't go on. And no testing is indicated. If any category is checked yes, then appropriate testing and or documentation of rationale, right? So it's like, this is a 55-year-old, yes. Then you just write, this is a 55-year-old and age alone isn't a risk factor to screen for labs, right? If there's no other history or physical thing that's coming up. These then are what I found to be very convincing charts on from this paper, from the SMART medical clearance paper. These are the charts that they put in there showing just length of stay. There's a number of charts, so it's nice to look through, but these were 2 of the ones that I found very convincing. And this is before SMART criteria implementation on the top. I think what's most impressive to me is that 27 patients here are staying longer than 72 hours. So that's like, I mean, there's no upper limit here. Like, it's not like, I mean, is this like 72 hours to the minute, or is this like a week? You know, like, what is this? So first of all, these are just staying here for a long time. And then look what happens to that number once they implement the SMART criteria. Mostly everyone gets pushed to like the 6 or 8 hour mark. So not only are you getting like more kind of leftward skew with a bigger, more people here, or is it right skew? It's left skew. Don't think about it. It's skewed. It's more skewed, but then you also don't have this crazy kind of bimodal distribution. It's almost like bimodal up top here, and it's not anymore down here. So you can just see that graphically. Okay. So key takeaways, just to summarize what we've talked about, there's a paucity of evidence for routine lab testing. In fact, evidence supports that it may cause harm if it's used as a way to, for psychiatric hospitals to stop the admission of a patient who might need it. It increases the ED wait time. It increases medical costs. And it's really not useful for determining the need of psychiatric admission or not. Psychiatric admission is based solely on history and physical. Now, I just remembered something the only other thing that I want to cover from my slides is I think a lot of the time we rely on the UDS quite a bit. And so you might be thinking, but that UDS really helps me. But the UDS doesn't as much. So history alone captures 91% of illicit substance use and 96% of alcohol use in the last 24 hours. For peds, you lose it because they're all either like, you know, pretending to be good and they're like, oh no, I don't even, what is marijuana? What's that? Or they're like, marijuana, I'm smoking a gram a day. And you're like, there's no way you're doing that, or an ounce or whatever. And so the self-report for the kids, I think, loses something. Now, this is my thought on this was I wonder if you added the parents screening in this. My guess would that would be go up, but I don't know. You know, but at least clinically, I find that to be the case where you talk to a kid and they say something and the parent knows something more. The other thing that I think is difficult with the UDS is that a test can't determine intoxication or withdrawal, right? So like amphetamines is positive for 5 days. So this person could have used amphetamines 5 days ago and now they're acting wild because they're just a wild person. And then you're like, oh, they're high. But like, are they high? You know, I don't really know, right? THC, it can be positive for chronic users up to 30 days, right? So these things a lot of the time aren't really telling us whether they're intoxicated. The only way you can know that is history and physical, right? They're showing signs of just having a ton of dopamine in their motor cortex and in their, you know, brain. And then each and every one of these UDSs, amphetamines, THC, barbiturates, they all have their own negative predictive values and positive predictive values. So it's like, I mean, you know, Wellbutrin can make amphetamines positive, and so can, let's say, Seroquel, right? So, but it's not making, you know, but then THC would be something different. Right, so there's these contaminants that can get it thrown in, and then it gets even trickier. It's also one of the costliest tests, so that's kind of a bummer when it's providing inconsistent information, and then it doesn't change disposition. So I just thought that was noteworthy because I think that's one of the things we always ask first is like, what's the UDS? What's the UDS? What's the UDS? And it's like, it's this, but did you talk to them? is I guess my point. Standardized protocols like the SMART criteria can assist the clinician to determine whether a patient would benefit from lab testing or not. And there's been more research on SMART criteria since then, but I just showed the kind of initial study that was published. So that's it for medical clearance. And those were the high points that I wanted to say. I think it's really difficult and because really it's a system-wide issue. So we'll see. Suicide risk assessment would be the next. So we deal with a lot of suicidal patients in the emergency department. Here's just a couple books that I like. I like this SADC book because it has a really good like risk. It has really good documentation. So if you just, there's a certain page in the middle of this where if you just go there and you like copied the whole thing onto Epic, as a smart phrase, it would be pretty decent. And then this book, I like the Practical Art of Suicide Assessment because it has more of the nuance of the interview itself. This is like my documentation book this SATIC book, and then the Shea book is like my interview book that I like, just for general. So here's some other thoughts from other papers. Really, suicide, and we'll say this about violence, is on a continuum. And if you're over here, you're probably going to get discharged. Yeah, I just don't want to live, right? Oh, do you have any plan? Not really. Right? Not really? No, none at all. Okay. Or completion of a successful, well, I don't see these patients because they success, so I don't see that. So suicide attempt, we see these patients, right? I tied a rope to a beam in my house and I put my head in it. Like, okay, you really have to show me now why you can't go to a psych hospital. Like, you have to give me pretty good reasons. But where it's, I think, more difficult is this kind of stuff. This especially SI with plan. And so I think looking at it like this, it's like, okay, this is pretty easy. This person's probably going to get discharged. This is pretty easy. This person's probably going to get admitted. But what do we do with the middle? And on the big book of emergency psychiatry, they split these patients with intermediate risk into 3 categories, which I thought was interesting. So they said, and actually I found it encouraging, because I was like, oh, we kind of do this. So there's these chronically suicidal patients. And when you see these patients, the real question you're asking is, are they above their baseline risk or not, right? Because you're always suicidal. So like, why are you here today? And is the reason why you're here today because of an elevated baseline risk, or is it for another reason? Really, that's the question. And if you are here for an elevated baseline risk, the next most important question is, can it be reduced? Because if it can be reduced in the emergency department setting, then that patient goes back to their own baseline risk and they can be safely discharged. If you can't, then you might have to lean toward admission. So that's your chronically suicidal patient. I thought those points were just like very succinct and very helpful. The other type of patient that we see a lot is the patient with secondary gain, right? So it's raining, right? My check is coming tomorrow, and so I'm going to be here tonight. So what we do in that case is we just have to say, so what are you really here for? You're telling us that you're suicidal, but like, what if you had a blanket? If you had a blanket, would you be suicidal? If you had a roof over your head, would you be suicidal? And oftentimes the answer is no. It just gets tricky because these patients still are at elevated risk for completing suicide, because if I didn't have a blanket and I didn't have a roof over my head, this world wouldn't be the greatest place, right? So you do need you want multiple team members documenting the same thing, that this patient continually says to other people that his suicidality is conditional on a blanket, on a shelter, and we're going to do as much as we can in our safety planning to give him those things. And so it's going to come to some compromise probably, where he's not going to necessarily get what he wants. You're not necessarily going to get what you want, but you're going to try to find some way to meet in the middle. And so I thought that was helpful. Medically ill would be the last patient that Art and I, this is now 3 weeks ago, we saw this patient. It was just so funny I think it was funny to him too. No, it was funny to both of us. So the consult said, SI with plan to hang themselves with cords. The consult was placed about five hours ago. We walk in their room, they're medically ill, they're in chronic pain, they have all the things. And there's just like all these lines laying everywhere. Like they're like on telemonitor, they like have the tubes sticking out. Like it's just like, and their SI is SI with plan to like strangle themselves with their lines. Like that's literally what the consult says. And there's like no sitter there. Like it's just a patient, like with lines, like literally like draped over their body and their neck. And we're like, so are you really suicidal? Because like, there's these lines everywhere. And the last time someone checked on you was 5 hours ago, right? And they're like, yes, all I want is for people to listen to me, right? which is what they're really asking, right? In Part B here, they're just asking for relief from their suffering. I'm in pain right now, and the pain is so bad, I'm going to kill myself if you don't address it. And what's remarkable to me is how that doesn't even work. I mean, this patient said that 5 hours ago, and then we got consulted, and they're still sitting there in pain. And so, really going out of our way to try to meet these things and be advocates for our patients as much as we can be, I think will help this. And then, of course, clarifying whether they made this because they actually want to end their life from suffering, or if they're hopeless. So they're drawing a distinction between a patient that is hopeless, which would be more concerning for suicidality, versus a patient that wants to end an end of their suffering. And because we can help patients with their suffering. Here's another interesting article by Bundy. So this is one way I was thinking about it, this kind of a model, 3 patients with intermediate suicide risk. And I kind of said this contingency-based suicide, so suicidal if you're in need of shelter, or suicidal if your boyfriend leaves you, or suicidal in these situations. And they give these 6 of these categories essentially in this Bundy article. They just say document the situation. I mean, we really do all this. So we document the situation, you assess and document the risk. So really the most important thing is just to show that you're thinking about risk. You're separating the risk based on static and dynamic. Static risk factor, of course, being they had one attempt 10 years ago, right? That's never changing. They'll forever have one suicide attempt 10 years ago. Dynamic, their boyfriend left them yesterday. Modifiable and non-modifiable, right? I'm not going to change the suicide attempt they had 10 years ago. Maybe I could talk to them about their relationships that are going well in their life to help modify this distress that they're experiencing regarding their boyfriend. Or maybe they know coping skills in order to deal with that. So inquiring about their coping skills. An acute versus chronic risk, right? So you could have an acutely low risk, but chronically elevated because you have chronic suicidality. You could have moderate for both, and then they would just be a baseline. You could have elevated acute over chronic, and then the question is how do I bring it back down to chronic, right? And then lethal means, like, do you have just a whole pile of medicine sitting there? This confused me a lot until recently. It just kind of clicked. Like, I was like, lethal means, what does this even mean? Like, I walk out on a Barton Road and there's like cars everywhere, right? Or like I go in my bathtub and there's like a hairdryer just right there. It's like this world is like a really dangerous place. But what they mean by lethal means is like large storehouses of medications, gun access, and kind of things like that. So it's things that the average person doesn't have. Basically, 50% of successful suicide attempts are with firearms. We probably want to know that. And then you document how you're thinking regarding the dynamic or protective factors, document why continued care isn't indicated, your treatment rationale, and then expert consensus. Here's a really cool mnemonic, the I Care 2. This is a third way, so as if you don't have enough ways. So a third conceptualization of suicide risk assessment. And this is a paper made by the psychiatric emergency department people. And it comes in a web app form. So you can download it on your iPhone. We really do, and this is for emergency doctors and psychiatrists. So some of this, I think we're gonna do very, very easily. So identify suicide risk, like this section is like, did they say that they were suicidal? And then if not, then if they did, then it's like, yeah, then they get a psych evaluation. You talk to them like they're a normal person. You assess for life threats. So, do you have lots of medications? Do you have guns? You perform a risk assessment. Your boyfriend just left you, right? That puts you at elevated risk. You reduce the risk. Let's do like these coping skills. Let's do a care plan. And then you send them a postcard. So that's kind of each of these steps, extending care beyond the ED and downloads. So I showed you the downloads here. They have some really good actually websites. This is stuff we already know. These are the first three sections: identify, communicate, assess, risk assessment, blah, blah, blah. Really, where I think we step in with our nuances at this point, the reducing the risk, the second R, that's why it has R2, because there's two Rs. And these are things that they say to do for every suicidal patient, which I thought was helpful. Lethal means counseling. What if you locked up the meds? What if you locked up the gun? Safety plan, involve family, and then prescribe medicine. So I just say this, that like, okay, we're doing this stuff, right? And then if they discharge, then you give them community resources. So that's it for suicide. So it's like we're doing this stuff and we could document that we're using this kind of thing. Treatment of agitation. So I wanted to cover just the psychopharmacology, but then I realized we should probably talk about verbal de-escalation for a second, because psychopharmacology is last resort. It's like if we were just going to talk about hard restraints, that's like last resort. So let's talk about first things first, but we'll get here in 1 second. Causes of violence, of course, there's three: premeditated, psychotic, or impulsive. I'm guessing this lady's impulsive. Doesn't look like she premeditatedly picked up this kitchen utensil, rolling pin. Premeditated, these people should go to jail, right? They're criminals. Psychotic, these people should go to Patton or psych hospital. Impulsive, these are, you know, your TBI patients, the patients that have a lot of drugs, and so they can't control themselves, and development delayed, right? So 2 and 3 are a little more treatable. The premeditated, not necessarily as treatable. It exists on a continuum, just like suicide. Agitation does, with verbal de-escalation, then chemical restraints, preferring oral over IM. I think sometimes we're a little too quick to rush to IM, and then physical restraints last. There's a great article from 2012 called The Beta Project, and this is on verbal de-escalation. This is straight from the article. They actually recommended universal screening of agitation at the beginning of the emergency department. And if they said that if a patient was 5 or 6, that they should have a psych consult, we won't tell anyone that, because we already have enough psych consults in our emergency department. But I guess that's food for thought. Then they have these 10 domains of de-escalation. Essentially, what they describe in the paper is like a circle. So the patient's like, I'm mad. And what they say, so they're very concrete guidelines. Just take 5 minutes and try to verbally de-escalate them. And they said that out of the patients that can be verbally de-escalated, almost all of them can be de-escalated in 5 minutes or under. So you just set your timer in your mind. I got 5 minutes, and then you just repeat what they say, basically, right? So you're mad because you feel like you're a psych patient. You feel like you're being treated unfairly. And then you add what you want to add in. But the problem is you said you were suicidal, and now we have to do a full assessment, right? And then they're still mad, and then they'll say the same thing. Yeah, you have to do a full assessment because you think I'm a crazy psych patient. And then you say, I don't think you're, and you just do that for like 5 minutes or for however long. And, you know, and if they continue to escalate, then you just take a step back. But I thought that was helpful to just kind of have an idea of how long to go about this, how effective it is, and all this paper has all that kind of stuff in it. This is from a follow-up study. It's also still the Beta Project, but now this is the year 2020. And essentially, they separate it into mild, moderate, and severe. You're beginning to think of chemical restraints, PO medication by moderate. So they're like getting up out of their gurney. They're kind of posturing a bit. They're just moving around a lot. You're like, this person's squirrely. Now they're at high, severe agitation. They're like punching people. And now you're like, yeah, we need to really do stuff. So you kind of got mild agitation, moderate, and severe. Mild, of course, you just talk to them. Moderate, you talk to them and try to get them to agree to oral medication. Severe, you still try to get them to agree to oral medication, but you're like much more likely to probably move to IM at this point. This is Patton's algorithm for acute agitation. Theirs is for verbal aggression, persecuted delusions, or severe behavioral discontrol. And the reason why I put this is just to show you how quickly and how high dose you can go. I remember when they gave this lecture for us, I was like, oh my goodness. I thought about it for like a week in terms of the dosage of these medications. So olanzapine, you just start. So they come in, they're agitated, they're singing. Here's olanzapine 20 milligrams with 10 milligrams PO preferred over IV, preferred over IM. I think it's important to remember that IV is preferred over IM. It's like some of these patients that are agitated have IV access, and then they're like giving them IM medication. It's like, that's not super nice. If that doesn't work, then you can start thinking of Depakote, and you load them 20 to 30 mgs per kg. So for a 70 kilogram person, you do start right out of the gate 750 BID, or 1,000 milligrams if you're using the 30 mgs per kg BID for 5 days, and then get a level. And then if they're still agitated, so you've added your olanzapine, they're swinging. You've added your Depakote, they're swinging. Then you go down to Lithobid, and you do it in 10 mg per kg in 3 separated doses. So what I mean by that is 10 mg per kg dose, 10 mg per kg dose, 10 mg per kg dose. And you do it over a 6-hour block. So time starts on the first dose, then you do another dose 3 hours later, and then you do another dose 3 hours later. And then you take a level at the beginning of the next morning. They use the long-acting formulation because there's less GI irritation, but then they switch to the immediate release for kidney protection. So then you switch to 1200 and 900. And then in addition to all this, you have PRN Ativan just sitting there in the wings. The beta is a little different because this is specifically for emergency department. They subcategorize people into 3 different categories: delirium, substance-related, psychosis, and undifferentiated. So delirium, low-dose antipsychotic; substance-related, benzos. Really, it's all benzos for like everything, like meth, alcohol, barbiturates, THC. It's like all benzos. And unless they're like over-sedated, so they're like angry and like sedated, then you would use Haldol. And if they're psychotic, then you use psychotics with benzos. And then if you just don't know, you use benzos. so in the ED, we tend to use, and I found this surprising because I think at least as soon as they go inpatient, we're like, oh, no benzos for you. But in the ED, it's kind of like, this person's swinging, here's just 2 of Ativan. Do you want some Ativan? Is that your favorite medicine? Here you go, here's 2, here's 3. Like, take the Ativan. So it's kind of more like that. Here's dosages in the same paper from the Beta Project 2020 of the Haldol. Droperidol is coming back now. It's cool because it has a short half-life. It's kind of, I mean, not a short half-life, a short onset of action. It's like if you give someone Haldol 5250, you're never going to interview them for the next like 5 to 6 to 8 hours, right? But because they're asleep. If you give someone droperidol, you're going to be able to interview them because it's not nearly as sedating, but it does have a little EPS risk. So you probably want to give it, in this case, they say midazolam. So that's effective. You can do olanzapine, risperidone, Geodon, which we don't really use. Benzos, they also have ketamine titration in here too, which I thought was fun. All right, we did it. Oh my goodness.